Hello. Welcome everyone to our symposium entitled Missing the Point, When Will Point of Care STI Testing Be Available for Prime Time? I am Candice McNeil with Wake Forest School of Medicine, and I, along with Phil Chan from Brown University, will be moderating this session. I want to remind you that there will be a live question and answer session for this symposium on Friday, September the 18th at 3:10 p.m. to 3:30 p.m. Eastern Time. Feel free to put your questions in the chat box as you listen to these talks today. Our first speaker is Dr. Charlotte Gatos, a professor in the Infectious Disease Division at Johns Hopkins University. She is the former director of the International STI Research Laboratory and has authored over 540 research articles. She is the former PI of the Center for the Development of Point-of-Care Diagnostics for STIs. Dr. Gatos will be presenting an update on current point-of-care testing. Her presentation is entitled, Where We Are with Point-of-Care STI Testing. Welcome, Dr. Gatos.
Thank you very much. Thank you to the organizers for this symposium for allowing me to speak today. So where are we with point-of-care testing? First of all, these are my disclosures. Our objectives today are to identify and consider the performance characteristics of the STI point-of-care diagnostic tests that are available now. And then we'll end with talking about the point-of-care tests that are currently in clinical trials and some promising tests in development. We've come a long way, baby. We used to have to look in the olden days by culture, looking in the microscope, and also performing enzyme immunoassays. Then we had the advent of the nucleic acid amplification test in the early 90s. And now we have near patient and point-of-care tests that can allow us to diagnose STIs. Looking at the overview of the sample types, they've changed too. We used to have to culture the cervix and the urethra. When we had NAATS, we were allowed to do non-invasive specimens. And now that we have point-of-care tests, we can use self-collected swabs and self-collected specimens. Why do we want to do point-of-care tests? Because we can immediately treat infected patients and treat them appropriately. We can reduce empiric treatment and improve antibiotic stewardship. We can also minimize loss to follow-up. This decreases the forward transmission of diseases, lowers the risk of sequelae, and gives us an opportunity to counsel the patient. Wait time is also important. Let's look at a point-of-care trial for a test for chlamydia and gonorrhea. In an emergency room, women were receiving pelvic exams. They were randomized to a routine test, which gave the result in 2 to 3 days, a NAATS, versus a rapid test result in the ED. In the rapid test group, 100% of the patients who were infected were treated appropriately versus only 56% in the routine test group. For patients who were uninfected, about 25% were unnecessarily treated in the rapid test group versus 47% overtreated in the routine test group. We have lots of point-of-care tests for STIs. Today we're going to focus mainly on chlamydia, gonorrhea, trichomonas, and syphilis. We recently published a review article covering many of the point-of-care tests for gonorrhea. Many of the things in this article are also appropriate for chlamydia, including things about cost-effectiveness, acceptability, and some modeling. So right now we have 5 point-of-care tests that are available to us: the GenExpert, Binks, the Awesome Trichomonas, and the Solana Trichomonas assay. And then we have the healthcare check for syphilis. Again, I'd like to reemphasize that point-of-care tests go hand in hand with self-collected specimens. This is the gonorrhea and chlamydia test by GenExpert. It has high sensitivity and specificity, simple to perform, has 90 minutes time, though, that is required. We like to think that this someday could become CLIA waived. Again, high sensitivity and high specificity, and it is an amplified NAT test. New kid on the block is the Binks test. It's a 30-minute test. Everything's on the cartridge. Ambient room storage. We can dispose of the cartridge when the test is over. The results come out as clear input. It's an electrochemical label that's released. It is amplified. It's FDA cleared for women for gonorrhea, for chlamydia and gonorrhea, for vaginal swabs for men, women, and urine for men. It's not, however, CLIA waived yet. This particular new test has high sensitivity for chlamydia and specificity, and high sensitivity and specificity for gonorrhea. This report included over 2,400 people in 11 clinics in 9 U.S. cities in the United States. The bottom line is that the tests were associated with performance that was no different from laboratory-based molecular assays. I'd like to talk about the chlamydia, the trichomonas, which is our forgotten STI. We've had a point-of-care test that's been around for quite a while. It's pretty sensitive and it's pretty specific. It's based on immunochromatographic mouse antibodies to the M protein or to the protein from the membrane of trichomonas. We also have the Solana point-of-care test for trichomonas. It's FDA cleared, it's moderately complex, it's not CLIA waived yet. Compared to the NAT reference, it had really good sensitivity and specificity, and compared to wet prep and culture, it was highly equivalent. We offered this test to women who request kits during the internet. It was an acceptability study, and basically the women thought it was easy to collect the sample, follow instructions, read and interpret the results for this self-testing assay, and they got the right answer. We've recently evaluated this in our emergency department compared to wet prep, and you can see that compared to the awesome Trichomonas rapid test, the wet prep missed 12 of the 25 positives, giving a sensitivity of only about 52% for the wet prep. Next, we let the women perform the test themselves, and this was compared to the research coordinator. They got the right answer. Only one patient incorrectly identified a positive result as negative, and this was confirmed by a NAT test. We also gave quizzes to these women, and basically they had a high level acceptability, and 95% of women believed their results. They were given a questionnaire before they did the test and after they did the test. After they did the test, 82% thought it was not at all hard, 81% would definitely test themselves at home, and 63% of women thought the testing was just as good as a clinician testing them, and 17% thought it was better. We asked the providers whether or not this changed their clinical management, and they said yes, it did. 48% of the time, 82% of the time if it was a positive test, and 41% of the time if it was a negative test. And then our last point-of-care check test that's available to us is the health check. This results in 10 minutes. It pretty much agrees with other treponemal tests, can be done on a variety of specimens, and easy to read with a colored band that says the test worked, and another colored band if the test is positive. It is CLIA waived also, and it's been used routinely in many situations, especially in some clinics and emergency departments. Now I'd like to switch and talk about tests that are in clinical trials and under development. The first one is the VISB test, and it tests for chlamydia, gonorrhea, and trichomonas in 20 minutes. You can see the operating scheme here. The sample is put into the device, and you click 1, click 2, click 3, and in 20 minutes the results are ready. This is a cartridge that shows a positive result for gonorrhea, and a control line that's positive showing that the test worked. In the evaluable subjects, which have been submitted to the FDA, you can see that we had high sensitivity and high specificity for chlamydia, gonorrhea, and trichomonas. I'd like to cover now a test that's in development, the MobiNAT. This is an assay that's being done with some collaborators at Johns Hopkins engineering department, and they give the results for gonorrhea in 15 minutes. The nice thing about this test is that also in 15 minutes rather, can show you whether or not the organism is sensitive or resistant to ciprofloxacin. You can see in the first panel at the bottom that gonorrhea is detected, and also the gyre wild type, which correlates with sensitivity for ciprofloxacin. In the middle panel, you can see that there was no amplification of the wild type, indicating a resistant type. And then in the last panel, no gonorrhea. I'd like to finish with ChemBio, which is a test for HIV and syphilis serology. This clinical data is in front of the FDA and meets their requirements. You can see you put the sample and the buffer in slot number 1, and then you add a buffer in 2, and you wait and read the HIV and the syphilis serology as well as the control line. This shows that the sample has antibodies to both HIV and to syphilis treponemal antibody. The nice thing, this has a little reader which improves the subjectivity of reading, so you get a clear-cut read of positive or negative, and there's capability in the future to send this to the clinician through the EMR or to the cloud for surveillance. This assay so far has been very sensitive and specific for both HIV and for Treponema pallidum. There's a lot of excitement about using point-of-care tests for dried blood spots, which can actually be collected at the home and mailed in. We have a lot of interest in this and have done some comparisons showing that at least for the syphilis health check, that it compares very nicely to the point-of-care test when it's done off of serum or plasma. There are barriers to implementation, however, financial and money. If it is a CLIA wave sample, the site has to get a CLIA license. The test has to be validated. And then, of course, there's all kinds of procedures and policies like training manuals that have to be done, recertification and showing proficiency of the operators. Getting into the EMR or the electronic medical records can be a problem and costly. And then there's always the complication of space and workflow, and the last for billing and reimbursement, of course. So in conclusion, point-of-care tests, both in primary care and STI care, and someday over-the-counter, have great potential. But as we just mentioned, there are barriers which have to be overcome. They can be costly, time-consuming, and require new learning skill sets. So I'd like to end with saying better point-of-care tests are coming. Some are here. The future is promising. And thank you very much.
Thank you, Dr. Gatos. So our next speaker is Dr. Jeff Klausner, a professor of medicine and public health at the UCLA David Griffin School of Medicine and Fielding School of Public Health. Dr. Klausner has been doing research on HIV and STD prevention, diagnosis, and treatment for 30 years. He is the former director of STD prevention and control services for San Francisco Department of Public Health and former branch chief for the CDC PFAR program in South Africa. Dr. Klausner will be presenting successes and challenges of point-of-care syphilis testing. Welcome, Dr. Klausner.
Thank you very much, and thanks everyone for joining in to listen today, and thank you to the organizers for putting together this important symposium. So I'm going to cover some aspects about the successes and challenges of point-of-care syphilis testing. Okay, so in terms of disclosures, on the following screen, I'm a member of the Danaher Advisory Board. I receive donated research supplies and research grants from a variety of institutions. We know right now in 2020, unfortunately, we have the highest STI rates in more than 25 years. And testing has been the foundation for syphilis control strategy since the 1930s. So in this New York Times article, which was a book review of Shadow of the Land, it talks about the importance of case finding through testing, notifying and tracing contacts, and treatment. And it's that cycle of case finding, notification, and treatment which has been critical to syphilis control. Currently, there are several rapid dual HIV syphilis and syphilis tests only. Varieties have CE marks, which means they're approved for marketing and use in Europe. And one, as we just heard from Dr. Gatos, the Syphilis Health Check, is FDA approved for use in the United States and CLIA waived. The basis for the treponemal antibody rapid tests is that they're highly specific to Treponema pallidum, although as some people may know, that can incorporate a variety of subspecies. So there can be occasionally cross-reactivity, particularly people from endemic areas in Central or South America, occasionally, and in parts of West Africa. The treponemal antibody actually rises earlier than non-treponemal antibodies and is known to stay reactive for life. Long-term cohort studies suggest about 85% will have permanent treponemal antibodies. And one of the challenges is that the treponemal antibody cannot distinguish between prior and current infection. So in terms of clinical management, it's often combined with the use of a non-treponemal antibody to determine the activity of infection. So I'm going to talk about the FDA approved test, which is the Syphilis Health Check. The Syphilis Health Check detects antibodies IgM and IgG. I'll need to update that. It targets three antigens, treponemal pallidum 15, 17, and 44. It's a lateral flow assay, which is a fairly simple bioengineering principle. It has a control, which is important. So if the control works, you know that the test was done correctly, and it's read in a minimum of 10 but no more than 15 minutes after specimen collection. So in July 2020, the CDC and the American Public Health Laboratory Association reported on findings from a meeting it had convened on syphilis testing about 2 years prior. And this was a systematic review that was done by Claire Bristow, who's an infectious disease epidemiologist at UC San Diego, myself, and Tony Tran, who's the laboratory director for the District of Columbia. And we looked at the clinical test performance of a rapid point-of-care syphilis treponemal antibody test, a systemic review, and meta-analysis. And the reference below will take you to that free open journal article. So I just want to highlight some of the findings from this review. So in our review, we found 15 syphilis health check studies. There were a variety of different studies done by different investigators. There was some variability in the types of reference tests, the type of specimen type, which is actually very important, and we'll get into that a little bit later, and then the sites of where the studies were done. So the first key outcome was we grouped the prospective clinical studies together, and there were 10 prospective clinical studies, and some were done by independent investigators using finger stick whole blood, which is a common way that the rapid syphilis test is used in clinics and in field-based screening. And the sensitivity was generally lower in those whole blood field studies, ranging anywhere from about 50 to 70%, but the specificity was generally above 90%. Now, there are also prospective clinical studies that were done by the manufacturer in accordance with their FDA agreed upon protocols, and here generally the sensitivity was higher, and the specificity was also somewhat higher. So key differences were those were FDA level studies with quality assurance activity, and also the majority were done on serum. And the overall synthesis of those studies estimated an sensitivity of about 87.7% and a specificity of 96.7%. In addition, there were 5 retrospective laboratory studies where the investigators used stored serum that had been in the freezer, and they compared those with standard laboratory-based treponemal tests. And you can see their performance for these studies overall was actually excellent, so 98.5% sensitivity and very good specificity of 95.9%. There were 4 studies which also included a non-treponemal comparator. So when we want to interpret the use of the test, or as a clinician, when I want to use the test, I don't just want to know, okay, has this person ever been infected with syphilis? Yes, no. I want to know, actually, does this person in front of me potentially have an active syphilis infection that requires treatment? So in these 4 studies, they also included the RPR value, and the RPR had to be at least 1-to-1. So it had to be measurable to be determined positive. And you can here see that actually we have some of the best performance when we use an RPR of at least 1-to-1, and there we have a sensitivity of 97% and 95.5%. And in general, rapid syphilis antibody tests do work better in the presence of a higher RPR. That's not particularly surprising because there'll be a higher amount of treponemal antibody that can be detected in the clinical specimen. So the clinical utility will vary. We found a sensitivity in our review ranging from 87 to 98%, a specificity from 95 to 96%. And how you use the test will affect what the clinical outcome you might be concerned about, which is the positive or negative predictive value. So is a positive test representative of a true infection in this individual? Is a negative test representative of the absence of infection in this individual? And that's going to depend on the prevalence of the population that you might be screening or testing. So with a 5% prevalence, the positive predictive value is actually only a little over 50%. So that means many tests will actually be false positives, and that's why it's recommended for clinical management that the rapid test also as a sequence, it's followed by a non-treponemal, an RPR, or a VDRL test. However, its negative predictive value is actually very high. So if you're looking to rule out syphilis infection in the population, the single rapid treponemal test is actually very good. And then in this slide, I increased the population prevalence to 20%. And now you can see the positive predictive value for a single rapid treponemal test is actually very good, 84%, also with a very high negative predictive value. So I just want to go through some recent studies which have used the rapid syphilis health check. And this was a study done in adolescents and young adults in Los Angeles and New Orleans, supported by the NIH Adolescent Trials Network. And in this population, the rapid TP positivity ranged from about 1.6 to 7.6%. So those who tested positive went on to further testing, and about half of these cases did require additional therapy. And those who tested negative, the algorithm stopped there, and they were informed that they do not have syphilis infection. And we've also done studies with the rapid treponemal test in Lima, Peru. And here you can see epidemiologically the treponemal positivity increases with age, and also it's increased in certain risk groups. So in female sex workers, in particular young female sex workers, there's an absence of syphilis infection in those under 30. So that's actually very good news and suggests that their control programs among female sex workers are working effectively. However, we see much higher frequencies of infection in menosexual men and transgender women. When we went on to do RPR testing in those who were positive, about 21%, about 1 out of 5 of those who were originally treponemal positive on the rapid test had untreated syphilis. So the screening with the treponemal test with a second RPR test did result in the identification of about 1 out of 5 people who needed treatment. And here you can see the distribution of titers by RPR status and by the subpopulation or risk group. The third kind of key use of rapid treponemal tests has been in health systems, particularly in screening for pregnant women. And PAHO now recommends a rapid point-of-care treponemal test in antenatal care. It's been introduced as a combination test, treponemal and HIV testing, at the start of what we call the algorithm in PEPFAR-supported programs around the world that are doing HIV screening in antenatal care in pregnant women. And this was, this report by Patty Garcia, David Mabey, King Holmes, and Rosanna Peeling, who was really the lead on the development and implementation of rapid point-of-care tests for syphilis globally. What was an important publication that came out about 7 years ago, which really set the framework for the introduction and widespread use of rapid syphilis testing in pregnant women globally. And there continues to be studies and demonstration that it substantially improves time to treatment for those women who are identified with maternal syphilis. So in conclusion, there is an FDA-approved rapid treponemal test available. It is CLIA waived. It's being used by researchers. It's being used in health departments. It's being used in non-governmental and nonprofit organizations. The test performance is very good. The testing strategies vary, and the utility depends on the population. So in select young sexually active adults that are at increased risk, the utility is good. Menosexual men, it is important there as a tool to exclude infection. And in pregnant women has been associated with higher coverage and treatment and prevention of congenital syphilis. So thank you very much for your attention, and we will be available to answer any questions.
Thank you, Dr. Klausner. Our next speaker is Dr. Barbara Vanderpool, a professor of medicine and public health at the University of Alabama at Birmingham. Dr. Vanderpool has been evaluating STI diagnostic assays for over 35 years. She is the current president of the American STD Association and the president-elect of the International Society for STD Research. Dr. Vanderpool's presentation is entitled Considerations for Implementation of Point-of-Care Testing in Real-World Settings. Welcome, Dr. Vanderpool.
Thank you, Candice, and thank you to the organizers. Especially thank you for letting me follow Drs. Gatos and Klausner, because I think they have set up perfectly what I want to talk about. I do have disclosures to share with you for entities that provide research grants to my institution or salary and consulting honoraria to me personally. So I want to start by talking about use case scenarios. And use case scenarios have been used in business for eons as they develop return on investment strategies and try to decide how to design their assays. But until the COVID experience, I've not personally been involved in interacting with industry to help understand what assay performance characteristics, including the logistics of how to perform a test fit best with which use case scenarios. So I want to share that experience with you a little bit because I think it helps us think through the tests that are available and the tests that are coming, but more importantly, helps us work with industry to design the tests that we want going forward in the future. So just like journalism, the questions are simple. They're who, what, where, when, why, and how. So I'm going to go over each of these in a little bit of detail. So when we're talking about the who, we're talking about which patients. Are we talking about symptomatic patients or asymptomatic patients? Are we talking about contact tracing, which the DIS may do in the field or may do in a clinical setting? And those people may actually have different risk profiles than symptomatic or asymptomatic patients that have come into a clinical setting. Where is the test being offered? Is it in a clinic-based setting? If it is, we probably need to think now about revising clinical patient flow patterns such that, like if they're doing in the UK, we have specimen collection first. So if the patient registers, they collect their specimen, a test is started. That means the test can be available more quickly than if we don't collect samples until the patient interacts with a provider. If we're doing community-based testing, obviously these are going to be self-collected specimens, as Charlotte already mentioned, but we also have issues about, do we need equipment? Does it have to be able to plug in? But we also have questions that we don't have in the clinic, which involve data sharing. And Charlotte mentioned this briefly, but think about the data that needs to get back to a provider in order to follow up with this person and get them treated, that needs to go back to DIS or some sort of health department notification process so that we can trace partners when appropriate, and needs to be reported as a notifiable disease. And then finally, when we think about over-the-counter testing, which is not far behind point-of-care testing, these problems are going to be even greater, and they're not insurmountable. We just need to think about them now. So then when we think about when and why, the when, if you think about what Dr. Klausner just talked about with syphilis, you can see that early infection, active infection, and lifetime exposures are actually different measures, particularly for syphilis. But even if we think about HIV, early infection is highly relevant, and some point-of-care tests are being evaluated that can actually tell you if this is a recent acquisition of HIV, which may impact treatment strategies. For syphilis and for treatable STI, we might want to only look at active infections and, for example, not look at exposures or not look at past infections. Therefore, we might want to actually detune point-of-care tests so that we're not detecting things that are not actively replicating. Technologies such as digital drop PCR and viable PCR can tell us that we have live organisms. And so when we adapt those to point-of-care tests, that will help us know that this is an active infection that requires treatment today. Lifetime exposure is useful for syphilis, obviously, and it might be useful for chlamydia, especially as an epidemiologic tool to understand population-level burden. When we talk about why, Mycoplasma genitalium is a perfect example of we have to understand why we're testing. So we can develop a point-of-care test for Mycoplasma genitalium, but we don't want to use it on everybody. We've not had any clear guidance suggesting that we should be screening asymptomatic patients because we don't have good data on whether or not there are substantial clinical outcomes related to untreated asymptomatic infection. But we do know that with treatment failure, if, for example, a man has been treated for NGU and he comes back in a week later and still has symptoms, wouldn't it be nice to have a Mycoplasma genitalium point-of-care test that you could run immediately and understand whether or not you should include treatment for that organism as well? And then that leads us to resistance markers, which is part of the what. What are we testing for? Well, so in that case with Mycoplasma genitalium, perhaps we want to be testing not only for the organism, but whether or not the wild type or a mutant is available, just like Charlotte showed with the product that's being developed for gonorrhea. And of course, we do need exactly those products for gonorrhea as well. We have to think, though, then about when and who we apply those to, as we mentioned earlier, because do you want to run a gonorrhea rapid on every person if your prevalence in your setting is less than 1%? Probably not, because as Dr. Klausner mentioned, then you get into positive predictive value issues. So there's a lot to think about here. And then finally, the how, which is what the manufacturers, of course, are very concerned with, is probably further down on the list, but still, of course, very important. And that talks about the complexity of the test. How difficult is it to do? Is it CLIA moderate? Can it be CLIA waived? Does it need equipment? Does it have throwaway equipment? Does it need a reader for the outcome? If you just think about that syphilis check that you saw that has the 2 lines, that's not the sort of thing that we're going to push out to a lot of untrained users, and particularly not for over-the-counter. We'll need something that has an output that says something like the word positive. Or when you saw what Charlotte showed with the click device, and I'm sorry I'm not remembering their new name, but that showed a large purple dot right next to the word gonorrhea. So the person that's using it knows exactly what they're positive for, and there's no misinterpretation of results. Finally, we need to worry about biosafety. Again, for people that are collecting specimens in the field, we want to make sure that they're safe and they're not exposed to biohazards. And we need to think about data communication. How do we get all these data back, as we mentioned before? And that leads me to just a little bit about implementation science and what maybe, hopefully, we've learned in the last 40 years. So based on all the things I was just talking about, I've developed a draft decision tree for clinical use. And this is something that I think we should refine as a field, and that we should try to push out to people who are thinking about adopting point-of-care tests. So the first question when you have a patient in front of you is, does this patient have symptoms? If the answer is no, we'll come to that. But if it's yes, a point-of-care test, because as everybody's already mentioned, we want to know what to treat them with today while they're here to stop transmission immediately. But if the answer is no, the next question is this person a contact to a known STI? Because they do have a higher probability of being positive, it makes sense if they're a contact to use a point-of-care test and get them treated immediately. If the answer is no, then we have to ask, is this person likely to return for treatment? So if you imagine a detention center where people are only around for 48 hours, or a homeless shelter where people are very fluid, maybe they won't return. And in that case, a point-of-care test, again, makes a lot of sense so that you can get them treated and they're not lost to follow-up. However, if they're likely to return, then because there are cost savings from using bulk tests done in laboratories, maybe you'll send the specimen directly to a lab, and that allows you to test for a full range of pathogens. But also, if the point-of-care test is positive, we probably need a test for antimicrobial resistance. This may be a point-of-care test, which would be ideal, or it may be that you have to send the specimen to the lab for that evaluation. And even if the point-of-care test is negative, you need to consider what that test had. If it's just a chlamydia gonorrhea test and that person still has symptoms when they present, maybe you now need to test for trichomonas and mycoplasma, so now you need to send the specimen to the lab. So I think that we're never going to see an exclusive point-of-care paradigm in every setting, but it's going to be this mix of deciding what's best, what's the most cost-effective. So I wanted just to share with you a few experiences that I had from when we implemented chlamydia testing in my lab over the years. The first one was culture, and when we started that at our public health clinic, the clinical staff told us these things. If this was an important disease, we would have heard of it before. If it doesn't cause symptoms, our patients don't care. And we don't have a way to get the samples to the lab within 24 hours and maintain cold chain. So what this tells us is that we didn't do an adequate job of preparing the clinical staff for a change in our paradigm. And then when NAATS came along, I'm not sure that we were much better at that part of the whole process. We just said, oh, we've changed over, we're doing NAATS now. But then we got questions like, my patient has never had sex, so how could this positive be real? So that means that the clinicians didn't have confidence in the quality of the results. And again, that's an educational piece that maybe we didn't bother to share well enough. I also still to this day have people say, oh, I collect urethral swabs even from asymptomatic men because it's the best sample. So they haven't really bought into the fact that male urine is probably the best sample. People often tell me, I didn't know you could use vaginal swabs, even though for more than a decade we have been showing data to show that vaginal swabs are the optimum specimen for chlamydia and gonorrhea and trick testing. People still send female urine that they collect in OB-GYN offices that's mid-catch or clean catch midstream urine, which is really not what we want for STI testing. So again, all of these things show us a lack of communication and education on our part for educating providers about what we need. And so now when we think about the providers are actually going to be the one doing the test, it becomes absolutely critical that we fix that. So McDonough and colleagues in the UK have actually developed a tool based on the COM-B model, and COM stands for capability, opportunity, and motivation as they influence behavior. And this is a typical model that is often used in implementation science, and McDonough and colleagues have developed it specifically for STI screening. And they look at these components. For example, if you look in the capability, you see that there's a physical capability that includes skills and abilities and proficiencies acquired through practice, so on and so forth. So this is called a change wheel, that you can change these pieces and make this work for your setting, for your patients, and the funding reality in which your clinic exists. And then you can disseminate this information to healthcare systems and non-healthcare settings that are doing screening to try and let them not reinvent the wheel. And here's the wheel that they finally developed specifically for STI testing. And what you see in the outer layer is all system level factors. But you can see one of the ones that I would point out to you is the green wedge, which focuses on normalization. And I think about normalization as sort of destigmatization. And so all of these things at the system level, which includes society, but also includes program and policy, you'll see that the purple wedge includes on the outer layer testing guidelines. And there's one of the wedges that includes incentives and reimbursement. So we need to think about the system level issues. The next layer in are the provider level issues that I've been talking about. We haven't done a good job in the past, and we need a better job to make sure that people are knowledgeable and confident about the quality of these tests and about how to run them. And then inside that is the patient level, where we need to make the patients understand what these tests can and cannot do for them, which will be critically important when we go to over-the-counter testing. So what have we learned? Well, hopefully we've learned that provider buy-in is essential, and that, in fact, writing papers does not get the message out. We need to do a better job of communicating with people outside the field of STD work, because a lot of the testing is done in primary care settings where they don't hear these talks. They don't read these papers because it's not their field. We need careful understanding of the populations and logistics if we're going to be successful with implementation. And we really need to worry about ancillary functions like partner management and surveillance. So the take-home message is that one size will never fit all, and that we really need to think about what we implement at each place we implement it. And use case information, when we share that with industry, academia, program, and public health, we have the best chance of actually making rational use case so that the tests that we need are the tests that industry is developing. And for each clinical site or each program, careful consideration of your use case will help ensure appropriate adoption and implementation of the assays that you want to use. It's just like the syphilis assay. You can't use it on everyone as a screening tool. You have to recognize that you need to ask people, have you ever been told that you have syphilis before, and not test the people who say yes to that, because that then improves the overall performance. We need to spend time and money understanding approaches that will influence uptake at the societal and practice program level, and eventually at the individual patient level when people are doing over-the-counter testing. And so with all that, I think that we're living in really exciting times, and I think that we're learning a lot with the COVID experience, and we should apply that to STI tools as well. And I think the opportunities are really endless right now. And with that, I will end and say thank you for your attention.
Hello, everybody. So I'd like to introduce our last speaker for the day. This is Dr. Cecilia Kurtz. Dr. Kurtz is the manager of the Emerging and Zoonotic Infectious Diseases at the Association of Public Health Laboratories, or APHL. She will be presenting data from her work as a CDC Laboratory Leadership Service Fellow assigned to the New York Public Health Laboratory. Looking forward to your presentation today, Cecilia. Welcome.
Hi, everyone, and thank you very much for tuning in to our session today. It's a great pleasure to follow Dr. Gators, Dr. Klausner, Dr. Vanderpool, and thank you for setting up the importance and consideration about using rapid point-of-care testing. So today I will discuss the implementation of a new laboratory within one of New York City's sexual health clinics for rapid chlamydia and gonorrhea testing. So let me tell you a little bit about this initiative. So it's not a surprise to this audience that STDs are on the rise, with 20 million new STDs in the US each year, and half of these are among young people aged 15 to 24. So this infographic has alarming numbers. 22% increase in chlamydia since 2013, 67% of gonorrhea, and 76% of syphilis cases since 2013. In New York City, we observe similar trends, and CTNG infections on the rise as shown here. Those are the rates per 100,000 from 2000 to 2016, and I added the corresponding numbers of cases to the rates shown. So the rates are a 20-year high, and in 2017, there were more than 70,000 cases of chlamydia and 20,000 cases of gonorrhea reported to the New York City Department of Health. So let me tell you a bit about the Dean Street Express Clinic in London. So in the UK, they also saw an increase in STI, and so they called for intervention and actions to improve sexual health outcomes. They recommend using the latest technologies into clinical settings to improve prompt diagnosis and treatment and reduce the cost associated. Similarly, CDC guidelines also recommend testing for CTNG using nucleic acid amplification tests for rapid and simultaneous detection and confirmation to enable prompt treatment. So after the Dean Street Express and the lab was implemented, there was a recent study that compared the regular clinic model in light gray with the Express model in black. This shows the moving average of daily attendance for testing on the y-axis per date, and found that the attendance was much higher for the Express clinic than the regular one, which were around 20,000 for the regular clinic and 60,000 for the Express clinic. So overall, the Express clinic for asymptomatic infection delivered faster time to result notification, which enabled faster treatment, reduced infectious periods, therefore led to fewer transmissions. And this is the model that we followed in New York City. So this is a very recently fully gutted and renovated Chelsea Sexual Health Clinic in New York City. And this is one, and it is located in one of the neighborhoods with one of the highest numbers of male syphilis, chlamydia, and gonorrhea in the city. So this is where our initiative is revolutionary. So the goal of the Express Clinic is to be high-tech, high-volume, non-judgmental, and affirming sexual health center, and provide a cost-free test regardless of insurance and or immigration status for asymptomatic patients that will be self-collecting their own specimen and will not see a provider. So for chlamydia and gonorrhea, syphilis and HIV, but also post-test counseling, linkage to care for HIV patient, on-site treatment for STI positive, linkage to PrEP and PEP. But so in order to follow the Dean Street model for the clinic and provide a quick turnaround time, we actually needed to implement a lab space within the clinic. So now we'll tell you relatively quickly how we went from this, that looks like a normal office, to this, a high-end state-of-the-art laboratory. So let me introduce you to the New York City Public Health Lab Quickie at Chelsea. So what is PHL Quickie? At the Express Clinic, asymptomatic patient can get tested for chlamydia, gonorrhea, syphilis, and HIV without seeing a clinician. The Quickie Lab is a new diagnostic lab that provides rapid testing for more timely diagnosis and treatment of chlamydia and gonorrhea. And so we're testing urine, rectal swabs, and oropharyngeal swabs. So what were some of the steps that were needed to build this new lab? So we needed to actually build the lab with architects and contractors, to decide which platform to use for lab testing, perform risk assessments, hire lab scientists, perform CLEP validation and verification, procure the instruments and reagents, to set up the budgets, write grants, do training, pass regulatory inspection, and so on. So let me go through some of those aspects right now. So that's the final design of the lab and the lab workflow that we came up with. So specimens are dropped off at the pass-through window in 1, and then that's where they get accession in the LIS system. Then they are assembled at the bench in 2, and they are then taken to the biosafety cabinet in 3 for sample preparation. They are loaded on one of our 2 instruments in 4, and then they are reviewed. The results are reviewed by the licensed clinical laboratory scientist and released directly to the patient via text messages. So another important aspect is the workflow between the patient, the clinic, and the lab. And that was a great collaboration with the Bureau of Sexually Transmitted Infection, who runs the actual clinic. So specimens are self-collected by the patient at the clinic, and an electronic test order is created. Specimens are brought down every 10 to 30 minutes to the Quickie lab and are tested. The CT&G test takes about 90 minutes on the instrument. Then the results are sent to the LIS system, verified by the licensed technician, sent back to the clinic LIS system, released by text messages to the patient via a patient portal. And all of it with an estimated turnaround time of 3 hours from the time the patient leaves the clinic to the time they receive a text with the results. So to achieve this quick turnaround time as well as high throughput, we decided on using the Sapien Gene Expert Infinity 48 technology. So that's a fully automated system based on real-time PCR that does not require batch testing and has a very short turnaround time, about 90 minutes for the assay. All of the reagents and control are contained within the cartridge shown here, and every cartridge is loaded with 1 specimen and run individually on the instrument. And there's many different assays that you can do, and then can all be combined on the same instrument as needed. So another important part of the process was to determine the budget, staff allocation. And the question we asked was, how many people are getting tested? So when we opened, some of the numbers we saw was about 400 tests per week, and we were spike after Pride. Most of the people came afternoon and evenings. So that's when the clinic is actually open on extended hours on certain days. And then that's when we needed staff to make sure we can test. And lastly, when we look at the number of tests, it was 50% of tests for urine, 25 OP, and about 25 anorectal. So this showed we need to encourage for free sites collection. So more and more clinics are encouraging free sites collection for urine because there is also evidence that both CT&G infection can occur at rectal only or OP only. So we analyzed some of the data we collected and calculated positivity rates. So from March 1st, 2018 to January 1st, 2019, we had over 12,000 tests for urine, 5,000 for OP, and 57% anorectal. Positivity rate was about 3%, 10% for OP and anorectal, and then for chlamydia, around 5% in urine, 2% OP, and 10% anorectal. So from this data, what we see is that the highest positivity rates are not in urine. And therefore, if you only test urine, you might be missing some STIs. And so then we actually looked at unique visits. And this is where the patient came in and collected all 3 sites. And we had about 2,000 unique visits. When we look at those, we had 67 tests that were positive for GC, 15 for urine, 39 OP, and 28 rectal. For chlamydia, we had 91 positive tests, 34 urine, 6 OP, and 54 anorectal. So what this data shows is that within the same patient again, if you do not test all 3 sites, you might be missing infection, and you cannot just test urine, since most of the infection are actually not in urine. So as a conclusion, as we have seen, there's a global increase in STI that has been seen in New York City, and that leads to increased transmission and increase the number of New Yorkers needed to be tested. So what we're doing at the Express Clinic and the Quickie Lab is to provide a fast and easy option for patients with no symptoms to get tested for CT&G, HIV, and syphilis without seeing a provider. We provide a very quick turnaround time for confirmatory lab testing. It's also anonymous and cost-free and open to anyone that's 12 years and older. So by testing a symptomatic patient and based on the number I've shown today, we're already preventing disease transmission and long-term sequences in patients with those infections. And with that, I would like to thank the New York City Public Health Lab and Dr. Jane Reichman and Dr. Dimitri Daskalakis at the New York City DOHMH for trusting me with this project, and as well as the LLS program at CDC. Thank you.
Thank you, Dr. Kurtz. That was a great presentation. I want to thank all of our speakers today for their wonderful talks and the audience for their time and attention. Again, I want to remind you that there will be a live question and answer session for this symposium on Friday, September the 18th at 3:10 p.m. to 30 p.m. Eastern Time. Looking forward to our discussion. This session is adjourned.